Hi, my name is Justin Collins, and this next presentation is going to be on the safe implementation of telepresence services. I'll just get up my slides. I think we're all much more aware of the benefits of telepresence and telemedicine during this pandemic. But what we've tried to do with a recent publication is to look at the infrastructure protocols and safety issues related to telepresence services. As many of you will know, one of the largest telemedicine studies done in the world was a study that was completed in the UK with the results published in December 2011. And this involves 6,000 people with chronic medical illnesses such as COPD, ischemic heart disease, and diabetes. And whenever they published the headline findings, they were really quite remarkable and got a lot of press coverage. They demonstrated a reduction in emergency admissions, A&E visits, bed days, and elective admissions. But maybe the most striking finding was this reduction in mortality by 45%. But we should note these were chronically ill patients. And if this technology had been applied to acutely unwell patients with the potential to make a full recovery, such as patients that are post-operative, then a reduction in mortality might actually have been a long-term reduction in mortality. And this was the sort of conclusion from the cost analysis that was subsequently done, and the reason that this was not deployed as an approach across the NHS. So what do we need to improve surgical training? Well, we need various aspects, and these can all be supported with telepresence services. If we have telepresence with agreed protocols, we can raise awareness of the benefits of training and also drive agreement through standardized approaches. Telepresence also improves accessibility to expertise and reduces costs due to a reduction in the need for travel. And if we bring all these aspects together, what we will find is further integration of surgical training into everyday working schedules. The current validated curriculums, this was the one that was done by the EAU group with robotic prostatectomy, has a baseline evaluation, e-learning, simulation-based training, then modular console training, and transition to full procedure with final evaluation. And we can improve this in various aspects. The two things that are really needed are objective benchmarked final evaluation to drive credentialing. And of course, we also need objective metrics, which would be applicable to all stages of the training. One of the weaknesses with this current curriculum is that the surgeon who is signed off as being competent could be presented with an unfamiliar pathology or situation in the OR. And this is when we need this sort of emergency telementorship where we can call a friend and ask them for advice. And again, this should be delivered with objective metrics. This is very much aligned with the thinking of proficiency-based progression, where you take a new skill, you have procedure characterization, and then you define the metrics. And once we have validated metrics, we can set benchmarks and we can say somebody is proficient rather than competent. Training can be offered in various settings, such as VR simulation, dry lab training, and procedural training. And actually, telepresence can supplement all these aspects with real-time formative feedback to improve performance from the trainee. With telepresence, what we're really trying to do is replicate the airline industry model to improve patient safety. And we know that the airline industry has a fantastic reputation for safety. If we have a control hub, then we can collect data and we can have centralization of expertise, but also collect the data to enable feedback to the community. Telepresence services can be delivered with audiovisual links and telestration, and our aim is to improve patient outcomes, reduce complications and readmissions, just as was shown to be possible in the whole system demonstrator study. And we can use this for elective and emergency services to deliver cost savings. If we think of the example of the airline industry, if a pilot is identified as having a suboptimal performance or technique in doing something like landing the plane, they're put on a simulator. and they train on the simulator to get their levels of skills up to a benchmark before they go back on the actual plane. And in surgery, if you have a suboptimal technique, this can often lead to a chain of events that leads to adverse patient outcomes. So we can break this sort of chain of events by giving people more training, but also supplementing it with telepresence services that share knowledge, innovations, and insight, and drive advancements through collaboration. So a big opportunity from telepresence services is to collect this data in real time and to use big data analytics from the community to not just identify when surgeons are subperforming, but also importantly, when they're overperforming. And if we can identify better ways to do training and better ways to perform surgical techniques, then we can share that across the community. This is the paper I mentioned earlier that's due to be published soon in European Urology Open Science. And if you look at the diagram on the left, you will see that it has a lot of similarities in the layout with the WHO checklist. But we identified within this group of experts consensus views on what was required for the safe setup and delivery of telepresence services. And we also recognize the importance of audit, and not just audit of the telepresence services, but also of the performance of the trainer and the trainee. And if we collect this data, then we can analyze it, we can use big data analytics, and we can improve overall. One important aspect that was identified was the need for the trainer to meet with the trainee before the operation and agree the op plan and the telepresence schedule for the planned operation. Safety issues that were identified were the need for hospitals and organizations to follow agreed standards, that the trainees and the trainers should be aware of train the trainer courses. So if a trainer goes through a train the trainer course, that should include guidance on how to deliver telepresence services optimally. The other thing that was addressed was the need for standardized terminology. So exactly as they have in the airline industry, it was identified that certain terms needed to be very clear, and the trainees needed to be aware that if a trainer, for example, said stop, 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 and this repeated 3 times indicates the trainee is to freeze and stop moving any instruments and to listen to what the trainer is saying. We also had classification of surgical procedures and related performance metrics. We agreed that any key index procedure could be broken down to a phase with a defined start and end point, that there are within each of those phases important visual cues to be identified and tasks to be completed. And if we had defined the errors both as technique errors and event errors, then we could have an early warning system to actually prevent people from having adverse events. So to give you an example of that, a technique error might be using the wrong grasper on the bowel or wrong amount of tension on the bowel, and an event error would be that this results in a serosal tear. And here we can see how this would enable us to collect data in an optimized way. So we take these surgical performance metrics, we disseminate them through digital training. Telementoring is not just for feedback, but also labeling of these data points, and we collect patient outcomes through data registries. Then we have a sort of audit loop to drive narrow AI and machine learning. And it should be noted that the surgical performance metrics will likely also evolve over time. So they're a good starting point, but they're not an end point. And the aim to take this data is not just to improve surgical performance, but maybe also to understand the limitations of medical devices and to work out where they can improve as well. So in conclusion, telepresence services needs agreement and guidelines to enable safe use. Key index procedures need to be defined with agreement on what those metrics are about the phases, visual cues, tasks, and errors. And if we make these metrics transparent and accessible to all, then they will really evolve over time and really benefit not just the surgical community, but most importantly, our patients. And we can do this in collaboration with different organizations and societies. Thank you very much for this opportunity, and I look forward to taking your questions now.